Alright, so next we're going to talk about bipolar disorders and cyclothymia. So with bipolar disorders, the lifetime prevalence is about 1 to 2% of the population. Um, Patients look a lot different when they're manic compared to when they're depressed. It's kind of interesting to see, but the same person will present wildly different. So that kind of is why it gets frequently misdiagnosed. So when you see someone who's so severely depressed, you can't picture them being manic. So you might just assume they have depression only. They have a much higher suicide rate than the general population. Males and females are equal um, with bipolar disorders. This is important for you to know. Um, the average age of onset is about 19, and new onset of bipolar disorder would be really rare in anyone older than age 50. If if somebody came in and they were manic after the age of 50, I would be seriously concerned about a medical or neurological condition or some sort of side effect to a medication. Remember, antidepressants and steroids can push people over the edge into mania sometimes, so you have to be on the lookout for that. It's equally prevalent in all ethnic groups. There's a high comorbidity with substance abuse in patients with bipolar. Anxiety disorders are pretty common. Repeated episodes cause worsening of the prognosis. Okay, so continuing on, bipolar 1, you have episodes of mania and depression, but depressive episodes are not required for the diagnosis. So, someone with bipolar type 1 could just have episodes of mania and then be euthymic and then go back up and have mania again. But most of the time we end up seeing patients who have mania and then they'll be euthymic and then they'll have depression. And then it'll just fluctuate between mania and depression. So patients need to have one manic or mixed episode, and in between, patients may be euthymic, depressed, or hypomanic. Bipolar 1 patients may experience psychotic features such as delusions or hallucinations, and these are not seen in hypomania. This is the difference. In mania, you can have psychotic symptoms, but in hypomania, you can't. So if you see that in a test question or something, you'll know which one's which. You don't even have to know how long the symptoms have been present for. All right. With bipolar 1, there's a worse prognosis than for major depressive disorder, but mood stabilizers like lithium and Depakote, they help to reduce the relapses and make the prognosis better. ECT can also work for acute manic episodes as well as severe depressive episodes. Here's the DSM-4 criteria for mania. It's a distinct period of abnormally and persistently elevated, expansive, and irritable mood that has to last at least 1 week or any duration if a hospitalization is necessary. All right, and during the period of mood disturbance, 3 or more of the following symptoms have persisted. 4 if the mood is only irritable, and have these symptoms have to have been present to a significant degree. So they're very grandiose, they have an inflated self-esteem, they don't sleep, they're more talkative, they have flight of ideas, they're really distractible, they have so many activities going on that at work, at school, socially, everywhere. Excessive involvement in pleasurable activities, so there's a high potential for painful consequences. So they'll do things like go on spending sprees, go have a lot of sexual encounters, and maybe get on the road and drive at really high speeds, make foolish business investments, etc. These symptoms can't meet criteria for mixed episode. Mixed episode is different than a manic episode. And the mood disturbance is sufficiently severe to cause a marked impairment in occupational functioning and social activities. So they really are impaired. and also they can have psychotic symptoms. So, any psychotic symptoms or any patient in a psychiatric hospital automatically meets criteria for bipolar 1 manic episode, not bipolar 2. Here's a useful mnemonic to help you remember symptoms of mania. Fast dip, so flight of ideas, activity increased, sleep decreased, talkative, distractibility, inflated self-esteem, grandiosity, and pleasure seeking. So, you guys are probably wondering what a mixed episode is, because I mentioned that earlier. Um, this is a kind of an interesting sort of episode. It's when criteria is met for both a manic episode and for a major depressive episode, except for the duration. Nearly every day during at least a 1 week period. So, for 1 week, they meet criteria for a major depressive episode and a manic episode at the same time. So you can go review those criteria. So they'll be involved in a lot of activities and not sleeping, but they'll say their mood is depressed and they may be irritable and they may have pressured speech, but they're feeling sad. So it's kind of a confusing thing to see when you actually see it in a patient, but it does exist and they are meeting criteria for both at the same time. And if they have a mixed episode, that would qualify for bipolar disorder type 1. All right, bipolar disorder type 2. History of one or more major depressive episodes, and they need to have at least one hypomanic episode. If it's a fully manic episode or a mixed episode, it's not type 2. It's bipolar type 1. In bipolar type 2, women are affected more than men. Onset usually happens before the age of 30, and the course is usually pretty chronic. Here's the criteria for hypomania. The biggest thing is they have an elevated mood. It lasts at least 4 days, which is shorter than for mania. Remember, mania had to last for at least 7 days, unless there was a hospitalization. So for hypomania, it's at least 4 days. During this period of mood disturbance, 3 or more of the following symptoms have persisted. 4 if the mood's only irritable. So they're very similar to the manic symptoms, but their symptoms are not causing as much significant dysfunction. So you can see criteria E. The episode's not severe enough to cause marked impairment in social or occupational functioning or to necessitate hospitalization, and there's no psychotic features. So mania versus hypomania, the key difference. Mania is associated with significant social or occupational dysfunction or with hospitalization, while hypomania is not. Treatment for both bipolar 1 and 2 is lithium or mood stabilizers like Depakote. And there's other types of mood stabilizers out there, but lithium, Depakote are the most common. Here's a little diagram showing the difference between bipolar type 1 in the top and bipolar type 2 in the bottom. As you can see, the bipolar type 1, they both 1 and 2 have major depressive episodes, but in bipolar 1, they have a manic episode. Their mood's going up way higher and causing a lot more significant impairment, where in bipolar 2, they just have the hypomanic episodes. Here's another graph showing when psychotic symptoms might come in the different bipolar 1 at the top and bipolar 2 down below. So you can see in bipolar 1, they have these manic episodes. And this patient here, he had a manic episode, and he didn't experience any psychotic symptoms. And then he came back down, and now he's euthymic, and his mood is fine. Then he goes back up, and he has another manic episode, which remember has to last more than 1 week or any length of time if there's hospitalizations. So he's manic, but this time the red dots indicate psychotic symptoms. This time he had psychotic symptoms with it, which is fine. And that means he still has bipolar 1 because in manic episodes you can have psychotic symptoms and it's still bipolar 1 as long as they go away when the patient gets euthymic, and it looks like they did. And then here, look, he gets depressed, he has a major depressive episode, and he has some psychotic symptoms there too, which happens sometimes in patients in the middle of a major depressive episode. And then the psychotic symptoms go away. And then he gets manic again. Alright, versus bipolar 2, where he's having a major depressive episode, and he could have psychotic symptoms here, but this patient didn't. Then he's euthymic for a while, and then he goes up to hypomanic for a while, for at least 4 days, no hospitalizations. And then he goes back euthymic, and then he has another major depressive, but this time it's bad, and he has some psychotic symptoms. He gets treated, they go away, and he turns back into normal euthymic. Again, remember this diagram from the psychotic disorders lecture. You have schizoaffective disorder on the top and bipolar on the bottom. Just to remind you the difference between the two, that schizoaffective has psychotic symptoms this whole time, and they have this mood. So this person's getting manic or hypomanic, now they're euthymic, and now they're depressed. But their psychotic symptoms are always there, even when they're euthymic. And they have to be there for at least 2 weeks, as per the DSM. Versus bipolar, where they only have them in these episodes only. Then you have cyclothymic disorder, which is kind of like a lighter version of bipolar. There's alternating periods of hypomania with periods of mild to moderate depressive symptoms. So they're not fitting the criteria for a major depressive episode ever. They're just having like a lighter type of depression. Sort of like dysthymia, but they have the hypomanic episodes instead of only the small depressive type of symptoms. So hypomania, light depressive symptoms for about 2 years, and they're never symptom free for greater than 2 months. So these two things are identical to dysthymia, the 2 years and not being symptom free for greater than 2 months. Also, they cannot have any history of major depressive disorder or manic episodes. And they can't have any psychotic symptoms. Lifetime prevalence about 1%. It may coexist with borderline personality disorder. A comorbid personality disorder worsens prognosis. This is pretty much true in any mental illness. If you have a comorbid personality disorder, it tends to worsen the prognosis. Onset between the ages of 15 and 25. Prevalence is equal in males and females, usually follows a chronic course through their life, and we treat with mood stabilizers. Here's another diagram showing bipolar 1, bipolar 2, and cyclothymia. You can see bipolar 1 gets higher manic episodes, and they get depressed. Cyclothymia is less, and less hypomania, less depressed symptoms. Bipolar 2, they get as depressed, equally depressed as bipolar 1 patients, but they only have hypomania.